So we have very eminent people with us today. Thanks to Sujit for all his charisma, charm in using to charm. He used all his charm to get these people together. So first, we have a first speaker who is Unnikrishnan. He's a guy with a big headphone on his head. So he is a shoulder surgeon working in the government medical college in Alleppey. Correct me if I'm wrong.
Yeah, right.
Yeah, so he is a very enthusiastic shoulder surgeon, and he's making a good name for himself in this part of the country. And he's also a very good speaker. So he'll be talking to us about the basics, investigations, and diagnosis about the Posterosuperior cuff tear. Now, the moderator, of course, all of you know, is our Mahesh Krishnan. He is like one of the first surgeons, young surgeons, to take up, had the grit and guts to like stick on to just shoulder arthroscopy and survive in this competitive world of arthroscopic surgeons. So his favorite hobby is like beating the drums. That is the chenda in the temple. He is an exponent in chenda, which is actually a long cylindrical drum you find in Kerala being played in. So most of the time he's booked for the chenda performance in temples. When he gets time, he does shoulder arthroscopy. That's Mahesh. He's also an excellent speaker and he's always there in most of our meetings to express his opinion quite strongly, actually. And then we have none other than our great Dr. Prathap, who was instrumental in starting the chapter of Shoulder and Elbow Society many years ago, and he's currently the national president of Shoulder Elbow Society of India. He works in Sunrise Hospital in Kakinad, and he is a person who does mainly shoulder arthroscopy, and he has been like up and down the entire country giving talks and speeches and teaching all the young surgeons about shoulder arthroscopy. And last but not the least is our greatest of all, Dr. Ashish Babhulkar. And I'm sure he doesn't need much of an introduction. All of us know him very well because he's been so closely connected to most of our programs in Kerala, and he likes Kerala very much. He has seen more of Kerala than any of us. Okay, and Ashish, I'm sure you have a lot of other places still to discover in Kerala which you have missed last time. Okay, and he is a certified scuba diver. I'm talking about anything other than shoulder arthroscopy. Okay, he's a certified scuba diver and also a very avid bird watcher. Okay, so and he's been to Kerala several times, and he likes to teach, and he likes to tell us about the finer points of shoulder arthroscopy. I've learned a lot from him. I used to be only just a knee scopy surgeon many years ago, decades ago. It was only after a short visit to Ashish who inspired me to start doing shoulder scopy. So welcome you all. I'm sure like you're going to have a wonderful time this evening. And Sujit, secretary, he's our firebrand secretary who leads all of us from the front and encourages us for all these meetings. It's his idea to have this kind of a Zoom meeting. Okay, thank you all for coming. I'm sure you'll have a wonderful time. And I think it's time for us to start. So thank you.
We can switch over to Dr. Mahesh. He'll take the proceedings.
Good evening. Good evening, respected teachers. My teacher, Dr. Schiller, also the president of AASK. My teacher, Ashish Babhulkar, Sujit, and the speakers, Dr. Prathap Kumar, and all delegates of Kerala Arthroscopy. We are actually fortunate to have such a big panel here because practically you can ask about shoulder, anything under the sun, anything. We have faculty strong enough.
Anything under the shoulder.
Anything on shoulder. Yeah, you covered anything other than shoulder. So anything in shoulder you can ask. My request is to all delegates is to explore them, utilize them maximum, because they can give you answers on anything without any ambiguity. So utilize them in this 1 hour, make it very interactive, take down your questions while they are presenting. This is very basic discussion like posterosuperior cuff tear, meaning cuff tear involving supra and infra. We are not going into the complicated aspects of cuff repair, even though if you want, they can answer you. But my job is to coordinate the game as well as limit the giants for not crossing the limits, because because the speakers are big enough. They might go into different arenas. So I will try to limit their discussion to the basic needs of our delegates. So take down your questions and feel free to bombard them, get maximum from them.
Yes,
With the
please.
permission of the President and Secretary, Dr. Unnikrishnan will be talking about how do you clinically diagnose posterosuperior cuff tears, meaning infra and supra. This is very relevant for a beginner because it needs little introduction, because once you know how to diagnose a cuff tear clinically, this is what I learned some 15 years back. I was a fellow with Dr. Babhulkar. Certain number of diagnoses will simply vanish from your prescription, like your cervical spondylosis, cervical disc disease, and your periarthritis, and more commonly your fibromyalgia, myofascial pain syndromes. All these kind of blah blah things will simply vanish from your prescription, at least will come in reduced numbers. Once you know the shoulder and the scapula is the main reason for periscapular pain. So how to diagnose a cuff tear is the most important thing in being a shoulder surgeon, rather than being able to put some angle somewhere and put the bites and put that's just operating the shoulder. But to be a shoulder surgeon, you actually want to know how to make a diagnosis of shoulder. If you really know how to make a diagnosis, there's practically nothing in shoulder that you cannot diagnose, which can be diagnosed on an MRI on alone. Practically everything you can diagnose. Everything. Keep aside a little bit of very rare things like tumors or blah, blah. So this talk is very important for a beginner. Understand how to diagnose a cuff tear. That's very important, and perhaps the most important talk of the day is what Dr. Unnikrishnan is going to give. So over to Dr. Unnikrishnan.
Good evening, everyone. The topic for me is posterosuperior cuff tear clinical and radiological evaluation. Shoulder pain is a common symptom by which the patient can present to you with an estimated point prevalence of about 26%. It is reported to be the third most common cause of that patient can present to you. And the most common reason for shoulder pain is rotator cuff disease. As clinicians, one should know how to differentiate from the pain due to rotator cuff disease and due to other problems in and around the shoulder. Just 2 slides about the anatomical and the functional considerations before going to clinical examination. One should know about the rotator cuff, rotator cable, and the crescent to know the actual functioning of the rotator cuff. This rotator cable is a thick fibrous band which spans between the posterior part of the biceps to the posterior end of the infraspinatus. And if the rotator cable remains intact, then the humeral head remains centered, and any injury to the anterior attachment of the cable, or especially in partial tears and traumatic tears, can affect the shoulder biomechanically and cause pain. And another functional anatomy you should know is the force couples. There are 3 force couples acting in shoulder. One is the transverse force couple. There is a deltoid rotator cuff force couple, the upper trapezius and serratus anterior force couple, and the coronal force couple, that is the infraspinatus and the subscapularis force couple. So this helps to compress the humeral head into the glenoid cavity, and this helps in the dynamic stability of the shoulder. And any problem with the force couple can lead to pain and injury. And it has been shown that in the case of a shoulder impingement syndrome, if there is a decreased activity of the scapular stabilizing muscles like serratus anterior, there is a high chance of impingement and rotator cuff tear. So to summarize, a patient with an intact cable system and intact force couple in transverse and coronal planes can have a rotator cuff which is biomechanically intact, although anatomically deficient. So the spectrum of rotator cuff disease varies from mere impingement to partial cuff tear to rotator cuff, complete cuff tear to rotator tear arthropathy. And the diagnosis is a combination of careful clinical history and proper clinical examination and imaging. So one challenge we can get in shoulder is unlike the other joints, the distribution of the pain does not narrow down the diagnosis in case of a shoulder. And the shoulder joint includes both glenohumeral and scapulothoracic movement. Any problem with the scapulothoracic muscles and can also cause pain in the shoulder. And in case of muscular individuals and case of females, large muscles can make palpation difficult. And in case of investigations, MRI studies often identify abnormalities that is unrelated to patient symptoms. So these are the unique challenges that you can get in case of a shoulder case. So a rotator cuff tear can be an acute event. That's commonly a traumatic event. Any patient presenting with a history of trauma suddenly comes with the inability to lift his shoulder, and also a chronic pain, chronic event like in old patients coming with a degenerative tear, or an acute on chronic event with a patient with a chronic shoulder pain with a history of fall and presenting with a sudden inability to lift the shoulder. So the common complaints are pain, weakness, and in advanced case, one can get a pseudoparalysis, a loss of motion, and due to the inability to show of the muscle function. And also in case of pre-existent periarthritis, one can get a loss of motion, loss of function, and also a combination of this. So the classical symptoms are anterior superior or lateral position. One can get the pain in the anterior superior position of the shoulder. You can get a position in the referred pain at the lateral portion of the shoulder at the insertion of the deltoid. And most of the time, the pain is activity related, and the night pain is one classical symptom and by which the patient can present to you. So one should always look for the other cause of shoulder pain, like referred pain, like pain from the cervical spine, pain from the lungs, pain from the heart, pain from the abdomen also. So always keep in mind that any of this condition can present with a shoulder pain. If you don't examine this patient, you can miss any of these problems. So the main purpose of examination is to diagnose a rotator cuff tear. If you have to diagnose associated conditions, if there is any, and you have to determine the severity of that cuff tear and the need of the surgery. And the examination is under these settings, as in orthopedics: inspection, palpation, movements, measurements, and special tests. Inspection, one should look anteriorly, laterally, and posteriorly. The classical finding you can get is a muscle atrophy. You can get the, in chronic condition, you can get a supraspinatus and infraspinatus fossa. Yes.
I request everybody to mute their thing. Somebody's some voice disturbance is coming. Request everyone to see their transmute status.
Srinivas can do that. Like Srini, you can mute others.
Some voice disturbance is constantly coming. Srini, please do that.
Yes, sir. Yes, sir.
Please, yeah. Sorry, only please go ahead.
Okay. So first of all, inspection, one should look at the anterior, posterior, and the lateral aspect of the shoulder. You look for the supraspinatus and infraspinatus fossa. In chronic cases, you can get a hollowing of the fossa with muscle atrophy. Always look for the deltoid atrophy, in which, in the cases of suprascapular nerve palsies and other neurological condition, you can get deltoid atrophy, which can clearly differentiate between a pure rotator cuff tear and other conditions of nerve involvement. Also look for the Popeye sign. You can see in biceps tear, and look for the abnormal position of the scapula or the spine in case of a scoliosis. And you can look posteriorly at whether there is any abnormal scapulothoracic rhythm, like winging of the scapula, the medial bottom of the scapula retraction. No. In chronic non-treated cases, you can get a subdeltoid bursa. Subdeltoid bursitis also, and also superior escape of the humeral head, and also a Gerser sign, which can be seen as a swelling in the superior aspect of the shoulder. In palpation, one should palpate at the intertuberosity groove. That's a bicipital groove where you can find the biceps tendon tenderness, and also you have to palpate the AC joint, acromioclavicular joint, where you can palpate any pathology of the acromion. And normally, the pain of the shoulder will be around the anterolateral or the lateral insertion of the deltoid. So, but in case of a cervical spine pathology, the patient can often point the pain around the trapezius area and or the root of the neck. So the site of the pain can also be a indicator for the diagnosis. So next to the movements, the active range of movement examines the quality of the rotator cuff tendon, and the passive range of motion examines the flexibility of the rotator cuff capsule. One should look for the painful arc. and any inconsistency between the active and the passive range of motion, you should look for any shoulder periarthritis or a nerve involvement. And while palpating, while moving the shoulder, one should also look for the crepitus, where you can see in glenohumeral arthritis and also rotator cuff tear arthropathy. So this is a you should look for the drop arm sign in case of a chronic cuff tear or a massive cuff tear. This is the drop arm sign. Ask the patient to elevate the abduct the arm and gradually lower down the other giving base of the arm. That is a drop arm sign. And this is another shrug sign, whether the patient used the periscapular muscles for elevation. You can see how the patient to lift the arm. Patient is using the periscapular muscles other than rotator cuff muscles for lifting the arm. So this is a classical sign you see in a massive cuff tear in when you move the shoulder. Okay, right. So this is another condition you can see in rotator cuff tear, that is a scapular dyskinesia. If you closely look at the, sorry for the voice, you can see the medial border of the scapula is more prominent in this case. Ask the patient to lift the arm. You can see the abnormal medial border. This is a classical case of scapular dyskinesia. So next is the special test. You should always look for the test for rotator cuff, test for biceps or slap, test for AC joint, test for scapular dyskinesia, and the test for cervical spine. These are the special tests one should do if you suspect a rotator cuff tear. So first one is a job test. Ask the patient to internally rotate the arm and elevate the arm against resistance. It can do an empty can or a full can test. The patient will point the site of the pain. Next is the Hawkins Candy test. This is a provocative test. Internally rotate the arm, then elevate the arm to 90 degrees. Internally rotate the arm. Again, the patient can feel the pain. That's a Hawkins Candy test. It is a very sensitive test, but not a very specific test. Next is the abduction exonotation test. This is a test you do in a massive cuff tear, especially if the infraspinatus is involved. You abduct the arm to 90 degrees, you externally rotate and ask the patient to hold in position. So you can see this is a classical Hornblower sign you see in a massive infraspinatus tear. So this is an external rotation lag sign. You hold the arm by the side, you externally rotate the arm, you ask the patient to hold the arm by the side. This is gradually the arm comes to internal rotation. This is the external rotation lag sign. Okay. This is also seen in massive cuff tear, especially involving the infraspinatus. So one should also do the Gerber's lift test because subscapularis, in addition to this posterosuperior cuff tear, is another important stabilizer regarding the shoulder. So as the patient internally rotate the arm, ask the patient to elevate and hold it for some time. The patient is able to do that. Okay. Okay. So apart from these tests for rotator cuff, one should always test for the biceps. That is Ayagasans and the speed test, slap, test for AC joint like cross adduction test, and test for scapular dyskinesia, and also test for cervical spine like Sperling's test. And one should also keep in mind the differential diagnosis of the cuff tear, that is a cervical radiculopathy, the impingement syndrome, the calcific tendinitis, the adhesive capsulitis, the biceps tendinitis, the glenohumeral osteoarthritis, and the inflammatory and the infective arthritis. So always keep in mind the cervical radiculopathy, infective or inflammatory arthritis, and adhesive capsulitis. These are all can mimic cuff tear. So coming to investigations, the common investigation we do is the X-rays, MRI, and the ultrasound. X-rays are commonly done for looking for any fractures or the malunions of the greater tuberosity in case of a traumatic event. So and also you can also look for any cuff tear arthropathy. Someone has classified this cuff tear arthropathy into the 5. And if you can grade the cuff tear arthropathy into 5, in grade 1, 2, and 3, you can do a joint preserving surgery. That's also an importance of X-rays in rotator cuff tear. And coming to the MRI, one should look for the 5 essential characteristics of rotator cuff tear. That is the location, extension, pattern, fatty atrophy, and the retraction. One can memorize by using the mnemonic pearl. But first of all, the order should be like this: location, extension, pattern, fatty atrophy, and retraction. So the tear location can be the posterosuperior or anterior tear. Posterosuperior is the infraspinatus and the subscapular spinal tear, or anterior or the subscapular, because the treatment is different in these two conditions. And regarding tear extension, there's Collins have classified the tear extension into 5 depending on the extent of the tendons involved. The type A is a supraspinatus superior subscapular tear, and type B is a supraspinatus infraspinatus spinal tear. The importance of this tear is that it correlates well with the posterior functional range of motion, and loss of subscapularis function is considered as a crucial for developing pseudoparalysis, and in case of Collins. And next is geometric classification by Buckard and Davidson. And he classified tear into crescent-shaped, longitudinal, and massive contracted tear with arthroscopy and MRI. So the crescent-shaped tear is a short and a wide tear in pre-MRI, and the longitudinal tear is a long and a narrow. The importance is that this crescent-shaped tear, you have to do an into repair with bond repair, and in a longitudinal tear, you should do a margin convergence technique. And in case of massive contracted and cuffed arthropathy, one can do an interval slide and an arthroplasty. So this is a case of a margin convergence repair you do in a longitudinal tear. And next, one should look for the fatty atrophy. That's a classical Guttarier classification, initially done in CT, which is evaluated in MRI also, in which the grade 1, 2 has got a good prognosis, and grade 3 or 4 had got not that much good prognosis. Okay, so one should also look for the fatty infiltration. And also there is a sign known as the tangent sign, where you see where you can see the supraspinatus muscle atrophy. If the muscle is above this tangent line, there is no atrophy, and if the muscle is below the tangent line, muscle shadow is below the tangent line, there is an atrophy. So another thing you should look in the MRI is the retraction, amount of the retraction in MRI. Fatty has classified retraction into 3. The type 1 is less retracted tendon, and type 3 is the most retracted tendon. As the retraction increases, there is a bone to tuberosity, bone to the footprint attachment, also chance of decreases. And one should also look for the bipolar rotational insufficiency, where the distal and the proximal half of the tendons will be insufficient, and also a phosphoric flop tear, whether the tendon folds on itself, and also the musculotendinous lesions of the rotator cuff, where your prognosis is not that good in sometimes. So whenever you got a rotator cuff tear, you should first take the X-ray and classify it into, depending on Hamada classification, into 1, 2, and 3, or 4 and 5. If there is a 1, 2, and 3, you can take the MRI. This is the flow chart. MRI can be classified into subscap tear. You can use the Lafosse classification for subscap tear. If it is a supraspinatus tear, it can be classified into partial thickness and the full thickness tear. And the partial thickness tear can be classified into Elman classification, like articular and bursal sided. And depending on whether it is more than 50 or less than 50, you can do the repair or not. And it's a full thickness tear. You should look for the retraction, the extent and pattern, and pattern, depending on geometric classifications and Collins classification. So depending on this flowchart, you can treat a rotator cuff tear efficiently. So the take-home message is, you should always do a history and proper clinical examination in case of a rotator cuff tear. Many conditions like infections, neoplasms, even though very rare, can mimic these shoulder conditions. Always examine the cervical spine, look for scapular dyskinesia and AC joint problems in these cases. And you should do adequate investigations, especially MRI, to plan the treatment. And you should follow the mnemonic pearl while treating a rotator cuff. And when in doubt, in case of a rotator cuff pathology, the rotator cuff repair should be reserved as a last options, as far as I am concerned. Thank you.
Thank you, Unni.
Yes.
Very extensive topic, actually a topic of a day of a conference, like diagnosis, clinical test science, an extensive topic, and you did a wonderful job. Thank you for your hard work. You covered extensively well, and I opened the subject for discussion. Any question to be clarified on how to diagnose and what way to investigate? What are we supposed to look for in MRI, in X-ray? Any question from the delegate is welcome. Make it very interactive, because we have a very esteemed panel here. So get the answers from them.
I think we can have the discussion at the end. After the 3 talks, we can have all together. That's awesome.
But okay, fine. That's okay. I mean, if anybody has a doubt right now, you can clarify. Yeah, because
yes, sir.
Yeah, please.
Sir, first thing what I want to answer, external rotation lag sign is basically for teres minor weakness.
It has been found out that external rotation in adduction is mainly the function of the infraspinatus, and external rotation in abduction is mainly the function of the teres minor. But in case of this massive cuff tears, normally this infraspinal and teres minor will both be injured. The tendon is will be injured, so it will be positive in this this massive cuff tears normally.
Okay, sir. Now again, sir, some in chronic cuff tears, sometimes for diagnosing subscapular Gerber's lift off is find little difficulty. So, is there any other test which you can suggest of sometimes because externally rotating and going behind and pushing sometimes it's painful condition for the patient. So
Yeah, there is another test known as belly press test, but most of the time Gerber's is the most sensitive and the specific test for this subscap.
What about bear hug test? Sir? What is the sensitive bear hug test?
Actually, I don't know much about that. Okay, maybe
That
Dr. Mahesh can answer.
that question is passed on to other speaker. Dr. Ashish Babhulkar, sir.
So the subscap is very tricky. Clinically, radiologically, and even sometimes arthroscopically, we can miss it. There is no test that is perfect. So the point you made was correct that sometimes internal rotation is difficult, and that's why we cannot do the Gerber's test. And I agree with Unni that Gerber's is one of the most reliable tests. But I rely on my own test where I keep the arm in abduction and do this internal rotation. And that's a much better test. But you must understand that subscap behaves differently. The upper subscap, lower subscap behaves differently. So on the published literature, the upper subscap is better tested on Napoleon. The lower subscap is better tested on Gerber and the ASB subscap. And when Gerber or ASB subscap is positive, it means it's a full thickness subscap tear because we have tested the inferior subscap. But 90% of subscap tears that we see are upper subscap tears. Partial tears, type 2 tears, type 3 tears are 90% of the tears. So that's why they're deceptive, and it's very unlikely any of these tests will be positive. There are a couple of other tests. Bear hug is not so reliable in my practice because the problem is because there are 5 powerful internal rotators. Each of them can substitute the subscap. Whereas external rotators, there's only infra and teres, and that's why you can test them much better. There's also Alex Laderman test where he moves the arm by the side into internal rotation by shifting the hand of the patient and moving it external internal. When all 3 tests are positive, it's a substantial sign. Definitely, specificity is very high. But just because your test is negative doesn't mean that subscap is not torn. We often find an arthroscope and we see how subscap is there. Both sonography and MRI have not reported it. So the best, the golden technique to diagnose it is arthroscopy.
So clinically, my view is never take up one test to diagnose a condition in shoulder, because in shoulder every test are sensitivity is, you cannot diagnose one particular condition with one test alone. You have to take into consideration the history and employ multiple tests to arrive at a diagnosis. So there is, as Sir said, there is no one single test to diagnose a subscap tear. Yeah.
Mahesh, John.
Yeah, John.
Mahesh, I have a question.
John, please.
Yeah, only what's the role of
Your voice is not clear, John.
What is the role of ultrasound in your practice? Because it's a radiological investigation is also covered. What is the ultrasound?
Yeah, Sarah. In my practice, ultrasound role is very limited. Usually take MRI in almost all the cases, but I know Sarah is doing ultrasound regularly. The advantage is you can get a dynamic assessment of the cuff. That is one thing. In partial cuffs also, you can get an assessment how the cuff tendon works. Otherwise, I don't know any other.
Ultrasound is a very easy and cheaper method. And since it is a dynamic, you can, if you have a good radiologist, its pickup is actually almost equal to an MRI. So there are, I think, people, shoulder surgeons who do their ultrasound themselves. And if you have, there are training sessions also. And they get a very good results because it's a dynamic study.
Dr. John has a very valid point there. Ultrasound, you can diagnose by yourself. The only problem is our patients when you send them to the radiologist, they wait at the last end of the gynecology patients. The ultrasounds are all lined up over there, and it takes more than an MRI time to get the report. So having an ultrasound machine in your OP is unmatched. You can definitely make the diagnosis yourself.
Is ultrasound to make a cuff tear diagnosis or to get other details of the cuff tear? What is that you say? the extent of retraction, extent of fatty atrophy, articular cartilage damage, SLAP if any, AC joint arthritis. These things can be, these things can be picked up by ultrasound.
Absolutely no.
These are what I
No, the basic question is, can you plan your treatment on ultrasound alone?
That's the question. Because if I want to operate on a patient, I want to know the extent of retraction, fatty atrophy, associated pathologies. So anyway, I have to go for an MRI. So why an ultrasound? Yeah, please.
Can I see in my practice I do sorry. Can I speak? Yeah. In my practice, I prefer MRI scan because I want to see the fatty infiltration. I want to see the amount of retraction, and also I want to see how much it is the infiltration, fatty infiltration. That's one which I am really worried about. You cannot you won't appreciate the amount of fatty infiltration in ultrasound. So I prefer to do that.
Maybe a calcific tendinitis and all, ultrasound may be more sensitive. But there are certain limitations.
There are certain limitations.
You need to have a very expert ultrasonologist with you.
No. It being dynamic, it has got its own role.
Yeah. I think ultrasound has a very important role in the diagnosis and to know the extent of tear and also retraction. Other than fatty infiltration, everything is commended. It's a very easy test. If you like the patient comes in, and within 2-3 hours, they spend 600 rupees and the report is ready. And if you feel like, it is a more retracted cuff, you can go in for an MRI to find out all the other stuff.
It's very cost effective. But what is that ultrasound can pick up what MRI cannot?
We have done actually a study of one of our DNB students' thesis. It's almost equal, same. Ultrasound, MRI and arthroscopic correlation we have done. But we have a dedicated ultrasoundologist who does
that's needed.
Ultrasound.
Yeah. Yeah, sir. Dr. Babhulkar.
Yes.
Yeah.
So just to add to that, Mahesh, if there's calcification, MRI will consistently miss that calcification, especially if it's in the subscap. The sonography is singularly designed to pick up the ultrasound. And then there are its and bits, other things, muscle recruitment, dynamic. Now, you can split the audience between ultrasound and MRI, but where I find ultrasound indefatigable, the undeniable truth is your post-op ultrasound of a rotator cuff repair. You send it to an MRI, it's going to show you a cuff tear, it's going to show you a high signal, and it's going to create confusion. If you do an insertional cuff tear, that MRI is always going to overshadow that and show you an oversensitivity. So my post-op re-tear or post-op scans for rotator cuff, much better done by ultrasound because it gives you a factual reading of is it intact, is it not intact? And even if it's intact, if it's not recruiting, there's no point, it's of no value. So sometimes you do a very tight repair and you do a non-anatomical repair by doing a margin approximation. The MRI shows it's intact, the shoulder is not moving. Is because on ultrasound you see there's no active recruitment. So there are, each one has its focus. You choose whatever floats your boat.
How often you do a post-op assessment of the healing? When in doubt, or you routinely do it?
No, routinely is impractical because of the numbers that we see. But whenever I see that the patient has done his rehab and is not happy, has pain, is not recruiting, or the strength is not adequate, I'll immediately send them for
definitely.
ultrasound.
That's one situation where ultrasound
10%.
has a definite edge over MRI. And calcification, of course. Any more questions?
Dr. Mahesh, I think we are going quite late. Shall we go to the next?
Move on to Dr. Prathap. Yeah. That's a good sign, Sujit. That's the purpose of our discussion. Let more questions come. Yeah. Prathap sir, let's move on to Dr. Prathap sir. How do we approach once we diagnose a cuff tear? Once we diagnose a cuff tear, how do we approach that patient? How do we take that patient for surgery, or how do we take that patient for non-surgery? How do we approach that case? The algorithm, the treatment plan will be discussed by Dr. Prathap sir. Over to Prathap sir.
Good evening. Good evening, Mahesh, moderator. Good evening, the President and Secretary of AASK has a nice initiative, and of course, good evening, Ashish. It's long time since we have talked. So, okay, thank you, Unnikrishnan, for the introduction. I will straight away go for the presentation. I've limited 10-12 minutes, and then we can have the discussion. Okay, greetings from Sesi. Why we bother about rotator cuff is mainly this is the one group of muscle which keep the center of relation between the center of rotation of your humeral head and center of rotation of your glenoid constant, whichever position your arm is, whichever load you are taking, whether it's internal rotation, external rotation, abduction, forward flexion or extension. So that is the relation which is going to keep the center of rotation there, and that is the one which is keeping the joint reaction force in equilibrium. So if you lose that, you will lose the congruity of the joint. You will end up with a point loading or a rim loading or a edge loading like your hip, and then they will end up with the osteoarthritis, which is called secondary to your rotator cuff, which is called the rotator cuff arthropathy. So that is the natural history of that. So we want to prevent that in case of a rotator cuff tear. So that is why we are possibly repairing that, and of course to regain the function as well. So the joint reaction force has to be in equilibrium. For that, you will have to have an equilibrium between your anterior cuff and your posterior cuff. Okay, so the posterior cuff, of course, as Unni has explained, the rest of your supraspinatus, infraspinatus, and subscapularis, apart from your anterior part of the leading edge of supraspinatus. Now I will just skip that. Okay. Now, a type of arthritis can be a traumatic or atraumatic, or a traumatic on a degenerative cuff. Okay, that you don't need. Okay, symptomatology already been discussed. What is the pain pathogenesis from the inflammation, impingement, stiffness, and there are a lot of the foci where you can get the pain, stiffness, weakness, unstable motion. That's the one which you need to keep in mind, and of course the failure of the fibrous endoskeleton. Now, pain in rotator cuff, don't forget about your suprascapular neuropathy, and also as I said before, the long head of biceps, which we are going to talk after a couple of slides, rotator interval contracture, and of course the AC joint pathology. When you talk about the treatment of management of rotator cuff tear, we need to answer certain questions. Whether the clinical outcome with the non-operative versus operative treatment, what is going to make the difference? What going to make the difference? What about the return to sports if the patient is a sports person or even a recreational sportsman? Chances of your tendon healing after repair, whether it's going to heal by itself or whether your repair is going to help it, and functional outcome at the end of your surgery or your non-operative method, and what are the chances of a repair re-tear if you're repairing it. Okay, and of course we need to explore what is the natural history of a rotator cuff tear. So that is the typical posterosuperior cuff tear, is involving only the supraspinatus, the middle part. You can see that the anterior cable, anterior leading edge is intact, so it's not crossing the limit of to the anterior cuff. Now these are the patterns. You can see a U-shaped pattern, you can see a C-shaped pattern, and you can of course see the vertical or horizontal extension of the tear pattern. Now this is very important. If you can, if you remember one of these papers from Etoy, he has defined who is going to respond to a treatment, non-operative treatment. So he has divided into responders and non-responders. There are certain things he has explained. Absent impingement sign or active external rotation, a good active external rotation, integrity of the muscular tendon on the MRI, then occupancy ratio of 75% of more of the muscle. These are, if all are present, then there's a high chance of the patient responding to non-operative treatment. So that you need to keep in mind. Okay, I leave that one. Now, there are certain things you need to keep in mind. Okay, posterosuperior cuff tear. You need to define it. You need to recognize the pattern of your tear. That is very important to decide on the final aspect of your treatment when you are repairing it. You may have to do a side-to-side. You are tempted to do a side-to-side repair along with the major repair. You may have to do a margin convergence depending on its tear pattern, or you may have to, if it's a retracted one, you may have to do an interval slide so that you can have an entirely tension-free repair. When these are muscle glide, if you look at the literature, there are certain papers coming out with the muscle glides, especially when it's a retracted cuff. The whole idea of all these procedure is to prevent a tension on the repair, or to have a good tension-free repair. So if it's a retracted cuff, you can practice muscle slide. You release the medial attachment, and it can be advanced. A certain purpose is up to 5 centimeters. And when you advance it that much, remember you got a suprascapular nerve contraction. So nerve release, suprascapular nerve release is a part and parcel of this procedure. Now, a word about the partial thickness tear. It could be due to intrinsic causes or extrinsic causes. Extrinsic causes mainly is your subacromial spur of a varying degree. Okay, and that if you can remove the spur, the patient will get a symptomatic relief, and also probably it can prevent the further extension. Intrinsic tear, the intrinsic tear, is due to the usually it's on the articular surface, and the partial lesions, the partial thickness of the articular surface of your supraspinatus. It can be surgical versus non-surgical, depending on the patient profile and depending on the amount of the extent of lesion, and depending on the patient's activity and his symptoms. So the patient is having pain all the time with the possibility of more than 50% thickness, then there's a high chance of this can go into a full thickness tear. So those patients may need surgical interference. Okay, so in situ or a completion tear, I started with in situ fixation, but I have moved on to completion tear and then repairing it as a full thickness tear. Certain patterns I will show. Ashish is going to show it in details. Single door repair, you will put your anchors, prepare your greater tuberosity or footprint, and then put it in the middle. Okay, so that away from the articular surface, so that it can cover. You can have a good coverage of your bone or a footprint, and then you can have a tension-free repair. A double door repair, where you can have a tension-free, you can approximate up to the lateral aspect of your footprint. You can put the medial anchor is very close to the articular surface, and the lateral anchor away from that. Okay, provided you can have a tension-free. A massive retractor cuff, you may have to medialize it even after releasing all these things. And if you think that is not, you cannot attain a tension-free repair, then you'll have to go for a medialized one. The idea is to get the force couple right, and to get at least some equilibrium in the in between the anterior and the posterior cuff. Okay, so then massive cuff tear with a partial repair. If you cannot medialize it, and if you think that you can repair the anterior, you can anchor the anterior side and posterior side, then that's a better option in that situation. Okay, in that situation, it's a better option. So again, the idea is to prevent. The idea is to get the center of rotation relationship quite normal, okay, or near normal. Chronicity and muscle, this is what we are just discussing. There's something between wasting and the fatty infiltration. Wasting in a younger patient, you can definitely have post-operative rehabilitation and bring that back to somewhat normal. But once it is fatty infiltration, it's an end game. You may not be able to do that, and that is the one that you can get a high chance of a re-tear after repair. Irreparable cuff, we'll just touch about orthobiologics in the rotator cuff. There are regenerative tissue patches available, PRPs. If you look at the literature, there are the people are divided on that. People who are favoring very much in favor of PRP, and people doesn't like it. And there are hyalurons involved in the treatment as well. Then if you look at the literature review, there are stem cells and PRPs used to boost the treatment of your rotator cuff repair. Role of tendon transfer. Again, we are talking about anterior and posterior cuff and the post couple. Okay, suppose your posterior cuff is intact and your anterior subscapularis is gone, you got a very good muscle which can recreate the pull, which is your pectoralis major. So you can substitute with your pectoralis major, and provided your posterior cuff is intact, so you will get a normal post coupling there. Similarly, if you got a subscapularis intact and you don't have a proper functioning posterior cuff, then you can substitute with the lat dorsal transfer, which can somewhat equate the posterior cuff. So again, the idea is to recreate your first couple and to avoid your rotator cuff arthropathy. Now, role of SCR, Mihata is the biggest proponent of that. Again, that is to prevent the superior escape of anterior superior escape of your humeral head, and to keep a platform where the deltoid can act on. abduct and forward flex there. So it's going to act as a platform to lever against it. Okay, so there's a paper. Subacromial balloon, I don't have much experience with that. I have used it, but I have seen a couple of patients who came from Birmingham for a review. And unfortunately, it's not like a literature. Unfortunately, both of them were failure, and the patient had pain and non-functioning shoulders. But if you look at the literature is the literature has got a different perspective. Probably that is somebody who is experienced a day in day out doing this type of a procedure. They can probably give a better result. So that's something which we can think of. A word about the compensatory movements. This is one of the interesting papers there. The compensatory movements based on the abnormality of if you have got a deficient cuff, then there are certain extra movements coming. One recruited muscle is your rotator biceps. If you got a posterior cuff or anterior cuff deficiency, then you got a recruitment of the biceps for increased movements. And again, your posterior deltoid muscles also recruited along with the accessory muscles. So that is probably, so the rotator biceps is used quite a lot, and probably that will act as a the point of pain or a source of pain. And probably that is one of the reasons why many people are interested in doing biceps tenotomy or a biceps tenodesis following a cuff repair. I don't do that routinely. And the reverse shoulder arthroplasty is, of course, if you all the hops are gone and not in the youngish group, if it's 50 plus, then you can consider a reverse shoulder arthroplasty. I don't consider for a 60 plus, but many people consider. I don't touch this sort of reverse shoulder before 60 years of old. And that is, of course, again, you will be utilizing your deltoid and an altered mechanism. Okay, your deltoid with an altered mechanism of your shoulder. So that is one of those algorithms. If you can recreate your rotator cuff, if you can repair the rotator cuff, well and good. Or if you can equate to your rotator cuff force couple rotator cuff to keep the force couple intact, like your tendon transfer or partial repair or SCR, whatever it be, that can also be tried. But if everything is lost, then you can consider the reverse shoulder arthroplasty. And if it's a candidate for a non-operative surgery, it's a contraindicated for surgery, then of course you can go for rehabilitation therapy and injections and other sort of modalities. So prognostic factors are, of course, the age, physiological age, not the chronological age, osteoporosis, cyst formation, then the duration of your tendon tear, because of again due to fatty infiltration and retraction and inflammation. So delayed patients, okay, but very late patients, you don't get a very good result, especially if the patient is 70 plus. So outcome depends on age, quality of your tendon, quality of your muscle, condition of joint, timing of surgery, and associated trauma or degeneration, and of course a surgeon factor. Okay, if you're confident that you are very good with the procedure, please go ahead. You've got a lot of alternatives, but this is something you need to be trained. If you are not familiar with one of these procedures, you need to be trained and then go ahead with the procedure. So take home message: please don't take a partial thickness hair or an ultrasound or MRI scan as a license to operate. You need a clinical examination. Uni has defined that how to do a proper clinical examination, and you need to correlate. Okay, and a clinical evaluation is a must. And patient selection, you need to talk to the patient. Patient selection is somebody you need a long rehabilitation. All these things patient has to be discussed with. I need a protocol-based rehabilitation. And over the phone consultation, I hate it, and I won't talk about that. I will give an appointment over the phone, but nothing else. I don't want people asking me, on the MRI, I got a tear, how much will it cost? God alone knows. If you want to know, come to my clinic. Thank you very much.
Thank you. Again, am I audible?
Yeah.
Thank you, Dr. Prathap, sir. Again, a huge topic, difficult to cover, and for the delegates also difficult to understand everything in detail. But if you have a posterosuperior cuff tear, when to operate, when not to operate, what are the candidates for surgery? We diagnose cuff tear and we take them for surgery. Somebody else suggests it is not for surgery. This is a common practice that we see in our day-to-day practice. So which cuff tears are to be taken for surgery? Which cuff tears are better treated non-operatively? According to the responders, non-responders has already been said by Dr. Prathap sir. And again, the treatment algorithm in nutshell has been said. So any doubts regarding this particular topic will be clarified right now with a few questions only, and then we move on to the last session of the.
Go on.
Yeah, Prathap sir, what is your take on whether you will do now at the present scenario? Will you do an interval slide to what is your indication for interval slide, and what is your indication for LHB SCR? In your current practice.
Yeah. I started using the LSB SCRs lot now because when there is a degenerative tear or a traumatic tear on a degenerative cuff, when the anterior cable and the leading edge is not very good or not very healthy, then I will definitely go for a LSB FCR, and I will do an extensive release in most of the cases, especially with the retracted one, because we need to get an edge which should be at least somewhat healthy. Otherwise, it's going to have a re-tear. So we need a sufficient tension-free tendon to put it back. So if I can't put it back where it should be, at least I can do a single rod repair or medialize it. I will settle for that. And any young patients, I will be very aggressive.
Extensive capsular release is the key to mobilization.
Yeah, I will definitely do. Yeah.
Interval slide, what you can achieve by interval slide, much more you can get by medialization. By interval slide, you are devascularizing the tissue. So,
medialization, I cannot get the tendon back to the footprint. Then I will, of course, think of
an anatomical as well as a tension-free repair is the goal. So if you do an interval slide, if you do without medialization, that results in an anatomical but full tension repair that is going to fail. So a good capsular release with medialization do better than interval slide sometimes. So in my practice, I do a capsular release, medialize, interval slide I stop doing now, even for any contracted cuff tears.
Yeah. I just one question to Prathap sir. Sir, is there any clinical test that tells you that this is going to be a very difficult repair on an irreparable tear? Clinically, not MRI, not ultrasound. Any clinical test that tells you that this is a difficult repair?
Those sort of patients clinically is going to be very difficult because of pain inhibition. You may not be able to test your the power of or associated muscles. It's a very difficult scenario. But if you got a good external rotation and if you got an abduction, so at that time we know it's going to be a better repair. And during surgery, if you got an anterior cable and if you got the leading edge intact, then we are quite happy that whatever we do, patient will have at least a good result.
That's a contracted cuff tear is a different entity from irreparable cuff tear. That at least
that's a different.
Is there any clinical test that I was asking? Any clinical test that tells you that this is going to be a difficult repair or likely an irreparable tear from clinical point of view?
Contracted cuff tear is something which you can diagnose arthroscopically alone. You try to mobilize the cuff. You find it difficult to bring it back to the anatomical footprint. You call it a contracted cuff tear. It's more common when the subscap is involved. A contracted cuff tear,
yeah, I understand. Just one more thing. If there is the ERLS external lag sign is positive, does it indicate it's going to be a difficult repair?
No. You can bring it back. Difficulty is contractility. Irreparability is a biological potential for healing.
So, Mahesh, I have a question here. Like on clinical examination, just by inspection, if you find the supra and infraspinatus fossa totally hollowed out,
yes,
you can see the scapula. Will you think of doing a cuff repair?
That speaks about fatty infiltration. That means that even if you repair it back to your footprint, that is the potential for healing is less. That is not a contraindication for not doing it.
Oh, you could still go ahead.
Right? I still go ahead. There are no signs for cuff tear arthropathy.
Can I talk now?
Yeah.
Okay, Schiller. If it's a young patient, then definitely whatever be the issue, I will try to repair it. But you have a very valid point. If it's infraspinatus and supraspinatus fossa is empty, then it's going to be a very difficult situation. That's why we'll have a look at the MRI scan. And if it's a completely fatty infiltration, repair is going to fail. So we may have to sort on with some other alternative methods like a SCR or a tendon transfer. So if it's a young patient,
of course, but still you can give it right.
No fatty infiltration I'm talking about.
Yeah.
Fatty infiltration.
Mahesh,
Yeah, Mahesh sir,
Leak
when,
rate is very high.
when there is a lot of fatty, when there is fatty infiltration, sir, what is the point in the trying a repair, sir? You know?
Okay. If fatty infiltration, then we'll have to go for an alternative. That's what I was telling.
Yes, sir. Yes, sir. That's
If
what
there
I
are no signs of cuff tear arthropathy with grade 4 fatty infiltration, is a hypothetical situation. But still, if there are no features of cuff tear arthropathy, what's the point in doing a reverse then? Unless you are not.
I didn't, Mahesh, I didn't say about reverse. I have given a series of alternative procedures there. So you can think of those alternative procedures.
Yeah, augmentation or your capillary SCR or the kind of thing. Yeah.
Can I add
You are good
something?
at reverse. I mean, Dr. Babhulkar.
Can I add something? Yeah.
Dr. Babhulkar, sir.
There are studies which show, like if once you do the cuff repair and once you start rehabilitation, this fatty infiltration will get reduced. Like the grade 3 will becomes grade 2. So it depends upon you do your repair and you're not grade 4, but as Mahesh told, it will be hypothetical situation. Usually in grade 3, it will improve to grade 2. Prathap sir, I have another question just to deviate.
Yeah.
Cuff, is there any timing for the surgery? Like, we all started from knee change to shoulder.
Yes.
Like in ACL, if you have a tear, people generally say, wait for the knee to be silent and then do. Is there any time period, like in a post-traumatic rotator cuff full thickness tear, is there any time period from the trauma to the surgery?
Okay. I don't delay surgery there. I don't delay surgery at all. But only if it's a fracture, but associated fracture, then only I will wait. Otherwise, I don't soft tissue cuff tear. I don't delay things. But usually by the time the patient comes here, it's going to be a couple of weeks. So I will go ahead.
An acute post-operative scenario, there will be invariably GT contusion, and where you are going to put your ankles on the footprint is going to be loose. So give enough time to the bone edema to subside. At least 3 to 6 weeks is a good time. And if you, on MRI there is bony edema, don't operate. Don't try to put ankles on there. Give some 3-4 weeks of rest until the edema subsides.
I don't think I will wait for 6 weeks. Okay.
No, 3 weeks enough. I mean, until that edema subsides.
Okay.
Yeah.
By the time patient, by the patient you are with you and do the pre-operative workup and get a day, it's going to be 3 weeks.
But, your MRI should not show any bony edema, subchondral edema, bony edema on the GT footprint area.
Prathap sir, I have a little difference. If you have a bony avulsion where it is with a small flake, or if there is a bony pasta, I would like to go in early. And
I know.
Traumatic.
I know you presented that. Yeah.
It's like Mahesh told, up to 3 weeks to 6 weeks to come back and do the surgery.
Yeah.
So what is the sir? Yeah.
Nice discussion going on. I think we should also think about the time factor. Our Babhulkar sir is waiting there. Shall we move on to the next talk?
Thank you very much. Thank you.
Thank you, sir. Thank you, delegates, making it very interactive.
I have a small question to Prathap before we wind up this session. Out of curiosity, it's nothing to do about the cuff repair. Like all those diagrams you had shown in your PowerPoint presentation, which were like signed by you at the bottom, Prathap. How did you exactly draw those diagrams? I'm curious. Did you use a mouse or did you use a pen?
No, I drew it on my mobile with the pen.
Okay. I mean, it's a bit difficult to decode.
Right from the beginning, you are asking unprofessional questions.
Thank you. I should have revealed this.
Over to Dr. Babhulkar, sir. Yeah.
Hi. After all those cheeky questions, let's get back to all this. So I know it's a difficult topic, and technically I can finish this talk in 3 slides saying that this is a posterior superior cuff tear. You operate or don't operate, both are equally valid in this situation. And thank you, Sujit and Team Kerala, for asking me to get on this AASK Wisdom Trail. I seriously have reservations where I can add to your wisdom, because a lot of water has passed, a lot of discussions have been done. Most of you are clued in. But I will try and share with you my 2 bits of experience. And I would like to explain some things as they have not been done, or probably in a very slightly atypical manner. So make it clear, especially for the younger ones.
Everybody mute their mics, please. All of you, mute your mics.
Fairly tricky. We've dealt with a lot of these options and in the previous talks as well. And as you can see, I have clearly marked this with a with a skull dagger here, that the interval slides are not a good option to deal with. You can do a lot of stuff in terms of releases, medialization, augmentation, but the interval slides are pretty much out of fashion now. Whatever you do, we are heavily leveraged on Guttiller classification, the whole team. So when my registrar wants to post a case and pre-operatively I'm checking on him, I will always ask him what is the Guttiller stage, and he will tell me. And we are fairly on the same platform whenever we discuss the Guttiller classification. Certainly don't want to repair stage 3, stage 4. I know John mentioned that there are patients who will reverse the Guttiller staging. Let me point out to Guttiller. Guttiller is a very eminent, very senior orthopedic surgeon. First published a study on the CT assessment of, so Guttiller's classification CT, and we mentioned Guttiller on MRI. So Guttiller's classification on CT-based classification. Guttiller's study, when he did this study, and then 5 years later, researched the same set of subjects again, 5 years post-cuff repair. Amongst them, 30 to 35% of his supraspinatus had reversed their Guttiller classification of supraspinatus, but only 18% of the infraspinatus had. This is food for thought. I want you all to chew on this. And at the end of the session, if we are still awake and alive and have the energy, we will discuss on what is this implication of this Guttiller classification. This is very important to understand. The other classification that we will and we will be on the same platform with our team is the Tomasio and the Pate. Tomasio is the description of the amount of retraction in the coronal plane, and Pate described it in the sagittal plane. Again, this is very critical. I need to know when my assistant is posting the case that is it Tomasio stage 2, is it Pate D, E, F, and such things. And that's your usual cutoff, because beyond this arrow, it could be repairable here. But if you go on the medial side of this arrow, I cannot confirm preoperatively whether I can repair it or not. I could have the best MRI, I could have all the clinical examination I want, but it can get dodgy. I'm not sure. So I'm going to now digress into this Philip Konop paper. And those of you who have read it, I'm sure you understand the importance of this paper. And those who haven't should go and read this paper. It makes a very interesting reading. And here I have put in, you can take a screenshot, that this is a type A where the red denotes the tear. So if you have a supra upper subscap and it becomes irreparable, you can always use either the lower trapezius transfer or the latissimus transfer. If you have something like this here, where you have mainly supra-infra gone, the subscap is intact, then we can use the SCR or the conservative treatment. Both are appropriate for this level of pain. And then when you're doing this, this is classical massive tear, supra-infra teres minor. I would either do a RSA or I would do a lower trapezius transfer or a lat torsi transfer. So let's dwell on this a little further and see what is the meaning of this. Where am I? Yeah. So from the pain point of view, the same classification, if you look at this classification, you will see that the group type E has a higher pain when the supra-infra and the teres minor are gone, and those patients, the rest have it. Now, the interpretation of this chart is that if you can control the pain on this patient, then you can leverage a conservative treatment on group type A, B, C, and D. But if there is pain, then they will need surgery. The type E, whether there is pain or not, they are not amenable to conservative because they would need function. And there's a lot of function loss in the type E group, and you'll see that further ahead as we go. Now, in terms of pseudoparalysis, you look at group A and group D, they have hardly any percentage of pseudoparalysis. Most of the pseudoparalysis group is the B, C, and E. Now, if you interpret this slightly differently, let's look at what's happening in type A and D. So the type A, your upper subscap is gone, and type D, you've got supra-infra gone. The force couples are still intact. So here in type A, the lower subscap and teres minor are there. Here, of course, the entire infra-extra. So the force couples will dictate the pseudoparalysis. So if you've got a subscap intact, if you've got a teres minor intact, it's still worth dealing with a conservative option. On some of this patient, they will give you a much more grief if they belong to type B, type C, and of course, type E is much more difficult. In terms of elevation, you will see that most of them tend to achieve reasonably well, except type B, because the subscap is gone. So the subscap is doing all the heavy lifting for the shoulder elevation. Take this statement home. So you need your subscap intact for the patient to be able to do active elevation, or even in a conservative managed patient, they come in late because the subscap is doing all the heavy lifting. So remember that. Active ER, again, most of the groups are good, type A and B, because the first couples are intact, but type E does the worst, because clearly when infrateres are gone, irrespective of whether the subscap is intact or not, the first couple is gone, they will not have a good external rotation. And not having good external rotation would reflect they have a poor function, poor elevation. That's important. Same thing in active external rotation 90 degrees. Only thing, if you see the difference between this group, where at 0 degrees, there is zero external rotation in the E group, whereas in 90 degrees, you get a little bit of external rotation, little bit. And that's probably because the teres minor is much more active in the zone, in that area, trying to compensate for that. Now, look at active IR. Irrespective of whether the teres minor and the infra are there, the force couple doesn't matter. So the force couple is irrelevant when you're dealing with intervention. What is relevant is the presence of the subscap. So in the groups like D and E, where they have a subscap that is intact, they have a very impressive active external rotation. So this is the interpretation, that with the subscap there, your active internal rotation is going to be quite good. If you have the force couple posteriorly available, they will still have a much better active elevation and control of the pain. So having dealt with that paper in a different manner, let's move on to the main presentation itself. Sibin was asking whether is there any clinical sign to differentiate a repairable or irreparable tear. I don't think there is any such sign, in the sense that I don't think we can say with any conviction. But if your patient has a pseudo paralysis and if he has this classic external rotation lag, you can take it from me, it's a massive tear. It may just be reparable, or it could be completely irreparable. So do be careful of these patients. Okay. So as I said, the Guthel classification, we use it on the MRI, and it's very important to understand that we are not going to take the patient in slide number 1 here, because this is not compatible with any form of repair. The supra-infra are completely washed out. The teres minor is gone. There's tremendous fatty infiltration right from triceps to subscap everywhere. You want this kind of patient in the center. And when you look at the last or the third patient, you look at this subscap wasting. There's a massive teres minor hypertrophy, and you can see what's happening to the supra-infra. It's gone, it's washed off. So the teres minor has been doing the heavy lifting for the infraspinatus till such time as they decompensate. This is not a patient for repair. This is a patient I have done a lower trapezius transfer. Okay. So we need to start with conservative, because conservative has been underestimated, not offered so oftenly. Even when in my younger days, I used to think that rotator cuff repair is the final answer to global warming. Unfortunately not. Over time, as I've wisened and as I've matured and seen my practice, there were several patients who refused surgery. This lady did refuse. She was 74 and she's an ardent swimmer. She swims every day. She has a large supra-infra tear and she lives alone. Her children are not with her. She drives a car and she said, since I live alone, I cannot afford 3 to 4 months of downtime. There's a lot of workload. She runs a factory. She said, I would prefer to do a conservative program. And she's done there. And she's almost 6-7 years conserved now, still doing well. I still meet her. She comes in once in a while, every year. The understanding that conservative treatment works doesn't mean that everything works. It works for smaller tears. It works for force couples that are intact, elderly patients, patients who don't have pain, with a limited goals. You can't expect to play tennis, badminton, do your gym in the presence of cuff tear. You'll decompensate very quickly. And they would need monitoring for the first 6 months close. Irrespective of how well they've done, the conservative management does not restore the supraspinal strength. Sports and weighted activity has been heavily restricted. They can deteriorate, and if they deteriorate, it will be disaster. They will go into pseudoparalysis, and then perhaps it would be only a reverse shoulder that would salvage them. So they need to understand that there is no silver bullet or a magic option for these patients too. So looking at this patient, 60-year-old, failed repair on the left side. This is a lady whose daughter is a doctor. He went into surgery in Surat. The surgeon went in very gung-ho, put a scope in and found out it was not repairable at all. Just came out because he didn't have a plan ready. Just came out. And the daughter was in theater, so he could not, obfuscate or give any excuses. So she came to me 8 weeks after that index surgery, and we saw clinically when we saw this 60-year lady, we realized that this gentleman operated a left shoulder and it is irreparable, no question about that. But the right shoulder also had a large tear, which he had missed out clinically. So we got MRIs both confirmed that this is exactly what we took her for bilateral simultaneous surgery on both shoulders. The left had a failed repair and there was a revision, which is what you're seeing here, and the right had a massive tear. So this is the subscap part of it. Let's move forward. And then this is the other end. So the left was massively failed. I revised that to a reverse shoulder replacement. The right was an undetected cuff tear. So we went in and did a rotator cuff repair with some augmentation with difficulty. And she's now almost 3.5, 4 years after surgery. And you can see, did an extensive release for her. This is the right side. With the release, I could manage to do the primary repair after medialization. And these are the releases that I would do for these last. So this is in a beach chair position, right shoulder. My reader frequency is between the cuff on your left side and the labrum. And these are staunch adhesions on the back side, posterior side. There are similar adhesions anteriorly underneath the CA ligament. And if you can release them, you can gain at least a centimeter or 1.5 centimeters of length, which is to me a big luxury. It makes an irreparable tear reparable. So we'll move that, you know what I did. And these are the similar releases on another patient. And same thing. Same thing. Okay. So this was the final repair. You can see there's a watertight repair. We've done a subscap repair. I've done an anatomical cuff repair. You cannot see the GT, tenuous quality. And if you can achieve this kind of repair on the right side, although it was a massive tear, it has saved her. We've done a cuff repair, arthroscopic, and who doesn't want an arthroscopic repair as opposed to a reverse? So this was the reverse shoulder on the left. That was a revision reverse shoulder. This was the repair. And this is her result after 1 year. And she's done fairly well. She's almost a 5 or 6 year follow-up now, mother of a doctor. So we have to be even more careful in addressing them. But almost full movement on both sides. And what is important is not only the actual movement, but we should be able to restore rotation. Now, with the cuff repair being anatomical, it's very easy to restore rotations. Giving rotations in the presence of a reverse shoulder, especially a revision reverse shoulder, is very challenging. And that is important. And that's a skill that has taken time to acquire. And you can see both external and internal rotation are almost full on both sides. Okay. So, mind you, any cuff repair cannot succeed without a subscap repair. So do not forget to check the subscap. Ensure that you understand the subscap. The subscap cannot be missed, because the subscap is missed, whatever you repair is going to fail. This is testing how well, and you can see it's coming only halfway through. And that's pretty tight. And then we should hopefully, that's the subscap part, be able to repair this by medialization and augmentation. So we've done this bit. And you can see on this side also that almost full repair has been achieved anatomically with the subscap. Yeah. So these are some tests that can, but if you ask me on a difficult patient, was this reparable preoperatively? I never know. I always keep the reverse on a back stable or prepare the graft. I never cut the biceps nowadays because the biceps can be used as an augment. So don't just go into the joint, first cut the biceps and then go and try and attempt the repair. I thought I would share a tip with you. This is a double row cuff repair I did for a patient. There's a spare suture there that comes with the anchor. I've not removed it. I keep it there till I inspect, and you can see there's a dog ear here. And in spite of a double row repair with 2 medial screws, 2 lateral screws, that dog ear has remained. And that can happen. So in which case, I have retained that sliding suture. Don't use the remnant sutures that have been tied, because they're not sliding. They will cheese cut through the bone or the muscle. You need a sliding suture. So I use that spare suture and try and close that dog ear. Use the hook to press it down so that you can, and there you close the dog ear as well. So that suture is usually discarded very quickly in a willy-nilly fashion. It's important to use that and ensure that you can cover up all the dog ears. So I thought that was an important perk. Which Sujit Jos asked me cover transosseous as well. So there are 2-3 techniques on transosseous. The arthrotunnel, which was made famous by Krishnan, versus Kuroda, who's a Japanese surgeon we have invited in 2016, and he has his own technique. And this is the tensor set. It's a very compact set, very slick, very impressive, sexy, but it requires these special needles and which are disposable. And this is a patient that we've done transosseous. So this is the guide that comes in. It sits in the point of your anchor there, and then you position it correctly on the GT and then pass the sutures through. And then once you pass the sutures through, you can railroad at least 3 sutures through one tunnel. So I usually use 2 or 3 tunnels. So then I have between 6 and 9 sutures there, which I can then sequentially pass to the cuff and then get them to heal up. And here you can see the cuff railroading those 3 pair of sutures through there. And so now that makes the job easy. Once you pass them through the tunnel, then the rest of it is like your conventional cuff repair, typical. And then at the end of it, once you've done your medial repairs, then you can sometimes augment this into a third row. What happened was some of the osteoid bone, the sutures are so strong, they cut through the lateral cortex. So immediately I took the medial sutures that were remaining and put them into a third row, just in case as a safety. So this was the first 2. The white and blue is the third row. The black and white and the dense blue are the second row. And we would still be able to achieve our goal of a watertight repair. So that's the anatomical repair. That's a subscap repair. And look at this. It's absolutely rock solid, watertight, anatomical. You can see that it measures nicely. These are the MRIs and X-rays after 1 year, and you can see the tunnel there. No implant, very sexy, looks very nice on the MRI, healed beautifully. So that's one of them. Quickly, let me just finish off with the strategies. L-shaped tears, put your scope in the lateral portal, anterior lateral portal, to gauge. This tear looked irreparable. And I was like, I have not talked about SCR for this patient. This is almost 10 years back. And I said, what do I do now? It doesn't look to be repairable, and this patient come from outstation. I've got to do something. So what I do is I switch my scope and put it into the anterior anterolateral portal, and then pick the eye strongs through the correct corner. And you can see that I can pull that almost through, except for the rotator interval, this small section here. So except for this rotator interval, which is fine, because I've left the rotator interval open. Technically, it's a partial repair, but really speaking, I've repaired the entire. So it depends on which corner you pull in. And that's very critical. If you pull in the correct corner, you can actually achieve an anatomical repair in this patient. And this you can freely leave alone. I don't want to do an over-tight repair on these. It requires a lot of mobilization. Margin approximation, I'm going to skip this because I don't like it. You can convert a V-shaped tear. Schiller, for your kind information, these are diagrams that were done by me, but I don't use my phone. These were done on the iPad. They're not bad, but you can see my signature somewhere there as well. So some of these shoulder surgeons, they're very quirky. I'm hitting the same bandwagon as Prathap Kumar. Now, this is the Fosbury tear. Unnikrishnan showed us the nice diagram of a Fosbury flip tear. And when you repair it, you must have a double repair. You cannot complete a Fosbury tear repair without a double row repair. So a single row will not work well. So you can see here is the Fosbury flip, and yeah, this is the final repair for the patient. Okay. Now, when just a word of caution, a partial, complete, incomplete repair, I don't like, because it is not like your proper cuff repair. The patient's pain scores are less, but the strengths are not restored. The re-tear rates are very high. Lisa Gellert's paper, 94% re-tear rates, although excellent pain relief. So be very careful. Of course, that was a very elderly age group of 75 plus. But I'm a big fan of medialization. Mahesh Krishnan mentioned that. You can see in those old days when we use metal anchors, instead of putting the 2 ones here, I put them far more medially. You can technically get a repair that is almost like normal, because you've done a tensionless repair. So you need not compromise the outcome of the patient. So given a choice, difficult tear, I would do a medialization rather than augment or any other technique. In terms of technique, sometimes there's a lateral leaf that is intact. So then you would want to repair that. And that's very tricky, because that means this is a muscular tendinous junction tear that is very dicey. I don't like them because sometimes the quality of tendon is not so good. But I will incorporate the lateral leaf also for whatever it's worth. But in principle, it is the medial row that goes into the footprint. That is your predominant repair. The lateral row, lateral leaf will cover that medial leaf. Don't try to join the lateral and medial leaf together, because that's a disease junction that is not going to survive. So use separate sutures for the lateral leaf to come in and then join with the medial leaf. Just a tip from my side. And then this is a final repair of the same lateral leaf, which has been welded into the medial leaf separately. And it's almost like a watertight repair. And then you can see from here that, yeah. So you can, it looks almost like watertight. But I like to keep that. And then you guys know that you can use a ripstop for the posterior superior cuff tears because that ripstop is important. So when I have a tenuous tendon and I want to repair it, so I repair the mattress fashion on the lateral side, and then I put one simple suture across perpendicular to that mattress stitch to help prevent the cut through or a type 2 failure. So that sometimes works, I think so. And then of course the lasso loop, whenever I think you're going to expect a dog ear, or whenever I'm doing a biceps SCR, I would use a lasso loop because that kind of reinforces that, clears the dog ear, and also makes it a much stronger stitch as compared to a conventional mattress suture. So you just come in there, pick up your suture, and just make that as a closed loop. So we'll go through that. Just a small final point, post-op MRIs, don't do them too soon. They are very, very deceptive. This is my patient and we've done it after 1 year. If I want to do my post-op assessments, I will always use an ultrasound because the MRIs done early was just going to show a notorious re-tear rate and the patient will freak out, you will freak out and take all the wrong decisions. Finally, augmentation. I believe in biologic augmentation. I don't think I would want to bet on any form of synthetic augmentation. There's a lot of promotion going on synthetic augmentation. I'm not so sure. Be very careful. There's a big push. Firstly, we don't have the patch that is a human dermal patch in India. What we are getting is the discarded patch, which is the xenograph from the USA. The results of xenographs in USA have been very, very dodgy. For me, if I want to augment, I would use the biceps. But I have to reroute. You can't keep the biceps there. You have to pull the biceps and reroute it into a central. That is when it works like a bridge. Your basic premise is that it has to prevent proximal migration. If it lasts for 8 weeks, 10 weeks, that's all you need to be, can retain, it doesn't matter. But I think the biological augmentation with the biceps reverse stenodesis or the bicep SCR is very, very, very reliable. And I would use it as an augment, not a substitute for irreparable cuff tears. I use it for those tenuous repairs, partial repairs, and that works. Just a spoiler alert, Schiller, this will be the last diagram that I've drawn. No more diagram from my side. You can always close your eyes when my diagrams come in there. LHB SCR, I think Prathap has already mentioned, so I don't want to go through that. As I said, I would use that as an augment. Never use it as a substitute for the cuff. It doesn't work. So it's just going to be a basic augment here. And this is the final picture of this patient where I've augmented. You can see the biceps is working like a bridge. It has been rerouted, so it has to be the center or the equator of the head of the humerus. You don't want it to be in the anterior end. And I always cut the distal end. Some surgeons do keep the distal end intact. I don't. We'll pass through this. I don't want to talk about patches. I have zero experience on patches, but there's a fantastic article by Joydeep Sinha, and that's very useful. You can go through the effort journal and you can see there are only 2 or 3 human dermal patches. All the others are fetal, bovine, porcine, and that's a big issue. I don't think that. There are very significant re-tear rates that nobody's talking about. 44% with the xenograph and Nihata with the SCR, only 11%. So this is exactly, you can take home the message, what I want to send as such. Last publication, even if there's a re-tear after a rotator cuff repair, patients are not too bad. They will still do reasonably well. 50% of the failed cuff repairs will still having a 72.7 ASA score according to this Kashian paper. Although the strength is not there, but their pain is there, gone, their main movements are good. So even a re-tear doesn't do too badly. We'll skip single row, double row. I'm a big fan of double row for very scientific reasons, but I don't think it's too pertinent. I'm a big fan of primary repair for all age groups. Our eldest patient is 87 years old. This is our publication for 70 plus patients. We had a 97% excellent to good result with no re-tears in this group. And that was a robust study that was published. So finally, after that exhausting, lengthy, boring, repetitive presentation, I would just like to say that the pre-op planning is very critical. We've spent enough time with, thanks to me and your discussions. Repairability cannot be decided pre-operatively. Whenever you're dealing with a 40 mm plus tear, whenever you're dealing with external rotation lag sign, whenever you're dealing with pseudoparalysis, be very careful. When you're dealing with hypothyroid patients, whenever you're dealing with 75-year plus patients, take it from me, be prepared. it may be irreparable, keep another option on. A subscap isolated versus subcap sleeve evolution are different tests. We won't talk about that today. And sometimes I will keep primary repair, SOS, SCR, but end up repairing most of them primarily because I would bet my money on primary repair instead of an SCR. Thank you very much. Just a concluding remark. The shoulder conclave is back again after a gap of 3 years thanks to COVID. And we have a doyen of top class surgeons coming in. And most of them are the absolute who's who: George Atwal, Alex Laderman, Ali Hachim, Teru Mihata, Ashish Gupta, Basam El Hassan, and Peter Thomas. It's a gallery of stars. And we're going to do 8 live eclectic surgeries. I would like most of you, I see a lot of fellows and friends who've been there on conclaves. We'd like to see you here next January. Thank you. Thank you very much.
Thank you, Babhulkar sir. Exhaustive, very informative, and most of the information I think has gone above the head. But
I hope not. I hope not.
Oh, that's a very, very interesting one.
Very informative talk. Yeah. A few questions can be answered.
Mahesh.
Sujit?
Mahesh.
Right?
Yeah. Mahesh, John.
Oh, John.
Ashish, excellent talk. Yeah, I have had, one question. Now
Yes.
this bursal augmentation is bursal tissue augmentation is coming up. What is your take on?
So there is a article which said that the bursa supplies a lot of the blood supply, which is true. And so when I'm doing my cuff repairs, I do very minimal bursal takedown, unless I'm dealing with a complex tear when I want everything very clear. But your standard run-of-the-mill cuff tear, I keep all the bursa there. I don't do any bursal augmentation because as it is, I remove very little bursa. I do very little soft tissue damage. I use very minimal radio frequency. I think that is what works in my hands.
So, hello. Yeah.
A
Hello.
few more questions.
Mahesh, Dr. Sibin here.
Hello?
Sibin here. Hello. Can you hear?
Yes, please, Sibin, please.
Ashish sir, excellent talk as usual. Lot of learning points. So just one question. So many of our patients, as you told, are usually diabetic and they have a component of stiffness along with the rotator cuff tear. It's a traumatic tear. They come after 2-3 months. There is a stiffness component. You know that there is loss of function and pain. Now, how do you go about that? And what is the line of management?
If you ask me, honestly, most of them are not stiff. They're pain-induced stiffness. So you can do 2 things. You can go ahead with surgery. The moment you give anesthesia, their movement is full. When you have genuine adhesive capsulitis, that will usually happen in the smaller tears. And I'm not too fussed about smaller tears. I just got them, put them on rehab, and most of them will recover themselves. They will refuse surgery because they've done well on rehab. Sometimes you're in doubt, so you can give a suprascapular block, which is just lignocaine 2%, and the pain goes away within a minute. And the moment that happens, they say my movements have improved. So that happens, then you're clear. A true adhesive capsulated and cuff tear are 2 different spectra. They usually don't mix. There might be 1 in 100 patients, in which case I have done both surgeries together very infrequently. But they're not happy patients because they take a long time to recover. Because the amount of soft tissue damage that you do, the releases, and it's just too much. And then post-op, you again immobilize them, so they're going to get stiff again.
Some stiffness is the rule in cuff tear, right?
Yeah,
Especially
all the time.
those involving.
That's why don't immobilize them. Don't immobilize them. We never immobilize them. My biggest enemy is the sling. By using the sling, you are forcing the rotator interval to get stuck again.
So how is the post-op mobilization, sir? What is the protocol?
So no sling, use the sling only in the car or at night when you're sleeping. Don't expect a jerk. At home, leave it down free. Drink a cup of tea from second day. Use your mobile with the operated hand. Read a newspaper. No problem. Start doing table washes. Our physios do a separate program on them, which are very easy, passive assisted, but you may not have that luxury. So just do table washes and increase the circumference is the safest exercise and it will prevent the shoulder from going stiff. At 3 weeks, I put them on active assisted with the stick. Forward flexion, abduction, external rotation, and also start doing wall push, front, side, and back, so that we're recruiting the cuff slowly at 3 weeks. That's again pain tolerance. If they find it difficult, painful, don't do it. The body is too smart. If you're damaging the cuff, the body will cause pain. It'll tell you don't do it. And if they can do it without pain, then everything's working perfect.
Okay, sir. Thank you.
So, sir, when do you try to achieve the full range of motion, sir?
If I wanted, I would like to get it done yesterday, but it is not for you and me to choose that. Nature does its own sweet course. Every patient is different because they come differently. Their amount of wasting is different. The amount of neuropathy is different. Their amount of pain tolerance is different. That's why I use lots of blocks. Take the pain away, they will mobilize easily. It doesn't matter. There are some patients who come at 6 weeks, full movement, and very impressive. They are so happy with surgery. I'm not happy because going too fast too soon is also not good. Going too slow is also not good. That cuff and GT isthmus has to be loaded proportionately as the type 3 collagen fiber gets into type 1 collagen fiber. So somewhere around 8 weeks, they tend to achieve 80-90% of their movement. But that's because they've done a 2-week supervised PSRP at that time.
After which, then strengthening starts.
No, strengthening starts at 6 weeks, straight away. So 6 weeks, they do a 2-week supervised program with TheraBands, no restrictions, and the team works with them. 2 weeks later, they must come at least 50% better than what they were. And then they're sent on the home program with the bands.
So what is your take on this pasta tear, sir? How do we manage?
Most of these small tears, even full thickness tears, I manage them conservatively. Any tear that is 5 and 6 mm doesn't excite me. So the pasta is an incomplete tear. So it doesn't excite me. Unless I have gone in, we did an instability yesterday, and he had a slab tear, and he had an anterior banca tear, and he had a frank pasta, which was 12 mm, 11 mm. You must understand a little bit of anatomy here. The supraspinal footprint, medial laterally is 12 mm. Most of us. So if you have a pasta which is more than 6 mm, 7 mm, it's almost 50% of the width. I would go ahead and repair that. But preoperatively, if the patient is clinically strong, I have no compulsion to repair it. You will have to really push me to do that. But anything that's 10, 11 mm, it's almost like a near full thickness tear. Don't call it a pasta. Go ahead, complete the tear, and just do a primary repair.
Ashish, I've seen you using your Liberator for, under the cuff. Is there any tips and tricks of using that without damage? Yeah.
Yes. Point taken, John. Firstly, use a blunt Liberator. Don't use the sharp Liberator. Today, I showed you both the blunt and the sharp ones. So the blunt one is safer. And I usually take the supra down and separate it from the adhesions posteriorly. And I think it's technically safer than using a radio frequency. You don't want to injure the cuff with the radio frequency or the heat as well. And I always do a spinal glenoid notch decompression. So that is where the supra and infra meet in the raphe along the spine of the scapula. So as I do that, I'm achieving two goals. I'm decompressing the suprascapular nerve in the spinal glenoid notch and also mobilizing the cuff adhesions there.
Dr. Mahesh, there are certain questions in the chat box.
Yeah, I mean, are we running short of time, Sujit?
I think a few sharpshooters for our quick questions for Dr. Ashish, Dr. Prathap, Dr. Unni. One question is in situ versus takedown repair. Dr. Harishankar has asked for a pasta. Quick answer, Dr. Ashish.
Well, to each his own. I don't think there's any. There's a study that did half patients in situ, half patients complete thickness. Okay, let me give you a pearl from my experience. If it's a young patient and a pasta which is only 5-6 mm, not near complete, I would do an in situ repair. But if it's a older patient, then I know it's a diseased tendon. Then I don't like that, because when you're dealing with a sick tendon, I would complete the tear, create a nice bed, improve the blood supply, and then do a takedown.
So acute, maybe in situ, and chronic disease.
Probably.
Go for a takedown. Yes, that's good.
Yeah.
There was a question from Dr. Rohit. He's been waiting for a long time. In a well-retracted tear, the MRI often overestimates the atrophy, because when you pull the rotator cuff back into its position. So what is your way of dealing with that confusion?
So it's very difficult to, so when you see the maximum wasting, if you start using a digital scan and you're on your computer and you're going from lateral to medial, and then before you reach the medial belly, you see a maximum fatty infiltration, which is under the AC joint. Then that's probably the retracted tendon. Okay, so that is fat substitution. But if you see fat substitution at the far end, medialmost end, that's true fat substitution. Now, this fat substitution is completely distinct from fatty infiltration. So if you see fatty infiltration anywhere, under the AC joint or medial to that or far medially, it's a disease, it's a neuropathy straight away. But the diffuse atrophy, when the muscle shrinks, is substituted with fat. If that fat is under AC joint, then it's retracted tendon. Whereas if it's medial most, then it's true fatty infiltration.
We have outshot the time anyway. Yeah, please.
Big time.
So can I just have the last question? It is a basic question. Sir, what is your, how do we manage cuff conservatively, sir? How a patient is not willing, so how do you rehab the patients?
So 2-3 things. The conventional rehab doesn't work in the sense that you don't want to generate pain. So you can give them a few blocks. Don't give steroids. you're burning all bridges with steroids. It doesn't work that way. You can do water pain management, ice packs, analgesics. But when the patients take them for physiotherapy, they are asked to do cuff substitution. That's all we write, because the team understands. Our physios are smart. They know what to do. So they'll largely start working on the scapular stabilization, because that scapula has gone for a toss. And unless the scapula comes home, the pain is not coming back, going away. So they have to get the scapular muscle back, improve their posture, and they work on the scapular postural muscles, work a lot on the core, and do minimal stretching, and never give empty can strengthening for the supraspinatus. What you should influence on is, number one, the force couple, that is subscap and infra. And if you can get the subscap and infra, especially if the tear is above the equator, then you can successfully get subscap and infra to work as abductors. Sometimes, because tremendous weakness, you can add deltoid, but you need a very experienced physiotherapist to add deltoid, because if you end up giving more deltoid and less cuff, you will cause proximal migration, which will lead to a loss of movement and a pseudo-paralysis-like picture. Of course, like surgery doesn't succeed in everybody, conservative doesn't succeed in anybody. You must see objective criteria of progress, which means that every week pain is down by 20%. Every week, range of movement is improved by 20%. Every week, the strength of subscap infra is improving by 20%. Sometimes you get lucky and the supra strength also comes back, but that is not the aim. That is not what we achieve. But if you can get the force couple and scapula in brief, the patient is going to be very happy. Collectively, in 2 weeks' time, if they are 50% better, recruiting, good. Now, what is the metric that decides that this treatment is working? And this is across all patients: frozen shoulder, cuff tendinosis, cuff repair, post-op. The patient wants desperately to get rid of pain. The physio wants to push and leverage the range of movement as a mask or as a measure of her success. I'm least worried about the two. The strength has to come back. The supra-infra strength has to come back. Because if the strength has come back, it's an indirect confirmation that you've achieved biomechanically neutral joint. To translate English to English, it means that the head has been centered into the glenoid. After which, the rest of physio just works like Zoom. And they said that till 9th day, 10th day, nothing was happening. 11th day, suddenly pain is gone. That is because the damn head came into the damn center of that glenoid, and the supra-infra then required just 20% power to stabilize this. And if after 2 to 3 weeks, that pain is not going down, strength is not improving, you're wasting time, it's not working. You have to think of plan A or plan B. In my hands, it's 2 to 3 weeks. In your hands, it could be 4 weeks. But there's no point giving reckless, indeterminate, non-time-bound physio for months together and killing that patient psychologically.
Great.
Thank you, sir.
Extensively covered the posterosuperior cuff tears right from the beginning, how to diagnose it clinically using a multitude of tests, how to clinically, which all to be taken for surgery, which all to be taken for non-surgery, what are the imaging modalities, and how we decide on the irreparability, the importance of subscap, the importance of extensive capsular release, and different tear pattern progression. And Dr. Ashish also has said the pseudo-paralysis pattern depends on the cuff tear pattern, the importance of force couples across the coronal plane. So a lot has been said, a lot has been discussed in just 1 hour time, and how much has gone into our head. Rewind it again and again, read it again and again, think it over, and let's improve. Anyway, a great initiative by the AASK, a great work by the speakers, legendary speakers, right? Super talk, super informative. All delegates' interaction was extremely nice. Nothing more to say. Over to Secretary.
Thank you, Dr. Mahesh. It was so nice of you to moderate this session. We had some cases lined up. Dr. Ashish, I think we can wind up now, isn't it? It's quite late.
Understand.
Yeah,
Absolutely.
10 o'clock. It's not fair keeping you back after 10 o'clock. It's already 10:15, 10:20.
Yes.
So Dr. Mahesh was not feeling well. He was hesitant to come in today. But then we forced, and Dr. Ashish is there, Dr. Prathap is there, wonderful speakers. Dr. Unni, you have to be there. I said, and I forced him. So let me take this opportunity. Schiller sir, let me thank all the speakers today, especially Dr. Unni for giving a wonderful insight into diagnosis, Dr. Prathap for giving us the algorithm to think and plan in our mind, and Dr. Ashish, of course, to tell us about the force couples, the medializations, the interval slide, which is going out, the biceps SCR, the latissimus dorsi transfer, all the concepts are there. And yes, Dr. Mahesh said many of things went above a little bit, went above him, but then the idea was to give concepts. The concepts are actually quite clear. When conservative works, when a small tear, like above the equator, when the rotator cuff is still intact, the conservative chance is more for a older, lesser demand patient. But when the tear is below the equator, either anteriorly or posteriorly, when the supra and infra are totally torn, there is no purpose in giving more of conservative treatment for months together. It may not work at all. Or you may advise for 3 or 4 weeks of rest and then come back. Or probably if it's a pseudo paralysis, like a local injection, probably can tell you whether it's going to be a conservative success. And one tip from my side is post of MRIs, I write specifically no report required. So no confusions.
Smart.
Only you get to see the images.
I like
Otherwise, you get the report, it's a mess. It's a mess. So 6 months, 1 year, if you want to get something done, or as Dr. Ashish is very luxuriously having his own madam doing the ultrasounds for him. Yeah, please. Dr. Mahesh?
MRI is contraindication, absolute contraindication in the post-op period.
Exactly. Especially if you get a report. Yeah, because there will be a lot of confusions. Basically, the edema, which is seen, and the radiologist will report everything, being like it will be innocent reporting. They will not know what to look for and what should be there. And especially when a younger person reports, it could be trouble unless you have a rapport with them and you can communicate with them. So thank you all the speakers, all the dignitaries who came here today. Let's have more wonderful sessions. Dr. Schiller, please, winding up word from you.
Oh yeah, I thought like you had already finished saying everything.
Yeah.
So thanks Ashish, thanks Prathap,
Thank
and
you.
Mahesh for like anchoring this show. It was really wonderful, and I'm sure like a lot of people who actually didn't ask questions were intently listening to what we were talking about, and especially the young surgeons. I'm sure they'll not go back empty-handed. They would have learned something new and which would help them in the day-to-day practice. Thanks Ashish, thanks Sujit, thanks Prathap. Good night to all of you.